So good afternoon, everyone. Today I'm going to be talking about narcolepsy, and so let's just get right into it. So here are some learning objectives, some things that we'll be going over during the presentation. How we define narcolepsy, describing underlying pathophysiology, recognizing the hallmark symptoms, associated features, and outlining some diagnostic criteria, and then we'll summarize some of the primary treatment options for this affliction. So, before we talk about narcolepsy, we have to understand how normal sleep-wake control works in your brain. So the brain has arousal systems, and it has systems that push you towards sleep. And orexin neurons in the hypothalamus help stabilize that balance, so they maintain that homeostasis. And as a part of this system, REM sleep is usually tightly controlled and doesn't just pop up wherever it wants, which is what narcolepsy is. Narcolepsy is basically what happens when that regulation breaks down. So narcolepsy is a chronic neurological sleep disorder where the brain can't maintain stable wakefulness and REM sleep boundaries. So clinically, it's defined by excessive daytime sleepiness and REM features leaking into wakefulness. And it can be divided into two main subtypes, so type 1 and type 2. Type 1 includes symptoms such as cataplexy, which we'll discuss more later in the slideshow, or low hypocretin, or both. Type 2 lacks cataplexy and has more uncertain biology. There's no real understanding of the major indicators of type 2. It's just if you have all the primary narcoleptic symptoms just without the cataplexy and the low hypocretin, then you probably have type 2 narcolepsy. So some epidemiology here. Narcolepsy is considered rare, but it's also significantly underdiagnosed. So the true number of people affected is probably higher, and many go years before anyone labels their symptoms correctly. So this can affect work, school, driving, relationships. So even though it's not the most common sleep disorder, the impact on quality of life is pretty big. So some etiology and pathophysiology. So in type 1 narcolepsy, we believe that there is a selective loss of orexin-producing neurons in the lateral hypothalamus. So without orexin, the brain has trouble staying steadily awake. And REM sleep features can appear at the wrong times. So these basically sleep attacks. There are also some genetic markers and environmental triggers that suggest an autoimmune process may be at play here in many patients. For example, if you have this HLA gene, this allele here, you have the propensity, there's a strong correlation for having that allele and developing narcoleptic type symptoms, or something in the environment triggering your body to start developing these symptoms because you have this allele. While type 2, though, on the other hand, seems more heterogeneous and is less well understood. So like I was saying earlier, you have all the symptoms of type 1. You just don't have cataplexy, and you do not have orexin or hypocretin deficiency. But you're still falling asleep standing up, and you have excessive daytime sleepiness and other sort of psychiatric disorders. So the core symptoms, of course, are excessive daytime sleepiness. And patients describe this as like an overwhelming urge to sleep, even after what looks like for them a normal night of sleep. And they can doze off anywhere, in class, at work, or even while driving. And brief naps are often very refreshing, but the sleepiness keeps coming back. All right, so cataplexy. I know that you guys are probably sitting there wondering what cataplexy is. Well, cataplexy is a hallmark of type 1, and it's a sudden, brief loss of muscle tone triggered by strong emotions, especially laughter. Um, so don't tell jokes around narcoleptics because they might fall over. Anyways, the key point is that consciousness is preserved during this whole thing. So the patients are very well aware that they're losing, muscle tone, and they're starting to collapse to the ground, and so they know what's happening the whole time, and it's usually accompanied by a certain level of REM intrusion, and it feels like REM-related muscle paralysis intruding into wakefulness. So that muscle paralysis that we all experience nightly when we go to sleep just happens to narcoleptics, like as they are having a funny conversation with somebody. All right, so other REM-related symptoms. So narcolepsy also features REM phenomenon at sleep-wake transitions. So this is like those hypnagogic or hypnopompic hallucinations that are very vivid and dreamlike experiences that we all have as we fall asleep or wake up. And they can be terrifying because they feel very real. So sleep paralysis is that temporary inability to move or speak during those transitions, again reflecting REM atonia, and in the wrong context, this is not good, especially if you were sitting there standing in the grocery line or something like that, and you all of a sudden you lock up and you fall asleep on your feet right there holding all your groceries, or God forbid while you're driving down the road. So nighttime sleep and other associated features. So even though patients are sleepy during the day, their nighttime sleep is often fragmented with frequent awakenings and vivid dreams. So they're not really getting great quality of sleep. So some people have automatic behaviors, so like doing tasks with little awareness and poor memory of them. So think about like in Step Brothers, where Will Ferrell and John C. Reilly were stuffing pillow cushions in the oven and like taking milk out of the fridge and doing all kinds of weird stuff. Well, this is a hallmark of narcolepsy as well. And on top of that, there's increased risk of other things like weight gain and mood or attention problems, which, this adds to the overall burden that narcoleptics face. So to diagnose narcolepsy, we have to start with a detailed sleep history. So because these symptoms they progress for years, mostly before anybody's ever diagnosed with narcolepsy, physicians have to start with a detailed sleep history, and often they get input from family or bed partners, and patients usually complete a sleep diary and will follow with an overnight polysomnogram to rule out other causes like sleep apnea. And the next day, we'll perform a multiple sleep latency test. And in selected cases, we may measure CSF hypercretin or look at HLA status. That's that allele that we talked about earlier. So, multi-sleep latency testing and polysomnogram findings. So on a polysomnogram, we mainly want to be sure that something like obstructive sleep apnea isn't explaining the sleepiness. And multiple sleep latency test then measures how quickly a person falls asleep during several daytime naps and whether or not they go straight into REM sleep during those naps. So short average sleep latency with 2 or more sleep onset REM periods is highly suggestive of narcolepsy. So especially when combined with cataplexy or low hypocretin. So differential diagnosis. Lots of things can make people sleepy. So narcolepsy is a diagnosis of careful exclusion. So we have to think about simple insufficient sleep, shift work, circadian rhythm disorders, sleep apnea, idiopathic hypersomnia, medication effects, and psychiatric conditions. So the history, the PSG, and the MSLT together help separate narcolepsy from all those other possibilities that I just mentioned. So when we get into treatment, there are non-pharmacologic management options for the treatment of narcolepsy. It's not just taking a bunch of meth to stay awake when you need to. There are different sort of treatments. Like there's different behavioral strategies that are critical for helping narcoleptics, navigate through life with this affliction, and which, of course, physicians always encourage a regular sleep schedule, and even taking short strategic naps throughout the day, which I think we would all love, and minimizing sedating substances when possible. And safety counseling is essential, especially around driving and job tasks. And sleep clinicians often work with schools and employers to set up reasonable accommodations. Now, pharmacologic treatments, so medications that help us deal with narcolepsy. So for daytime sleepiness, we use medications that promote wakefulness, i.e., these include agents like modafinil or traditional stimulants, and in some settings, newer drugs like solriamfetol or pitolisant or pitolisant. I'm not sure how you say it. But the choice of medication depends on the patient's comorbidities. You got to think that a lot of these narcoleptics, they're also coming with a lot of other pathological baggage, and then you got to think about the side effect profiles of these medications, and sometimes insurance and regulatory constraints. Really. All right, to treat cataplexy and other REM-related symptoms, sodium oxybate is a key option that can also improve daytime sleepiness. So we also use REM-suppressing antidepressants, such as certain SSRIs, SNRIs, or tricyclics, which can reduce cataplexy, hallucinations, and sleep paralysis. Well, all of these require, careful titration and monitoring for side effects and possible interactions, especially the antidepressants, because once you stop using them, you have to carefully back off of them. So prognosis and long-term management. Narcolepsy is usually lifelong, but with the right combination of behavioral strategies and medications, many patients can function very well. So early diagnosis reduces the risk of major accidents, major complications from having this disease, and can prevent secondary things like secondary mental health problems and academic failures. But ongoing follow-up with a sleep specialist and connection to support organizations can make a big difference in long-term outcomes. So to wrap up, narcolepsy is a chronic neurological disorder characterized by excessive daytime sleepiness and inappropriate REM intrusions. And type 1 is linked to a loss of orexin neurons, and cataplexy in type 2 is similar but without cataplexy and with less clear biological factors at play. So accurate diagnosis requires good history and objective sleep testing and management that blends lifestyle measures with targeted medications and safety planning. All right. Anyways, that concludes my presentation. Good night.